Matuzsan. I'm an emergency medicine physician and pre-hospital EMS fellow.
Good morning, good afternoon, good evening. I want to get right into it today. This episode of the podcast is very special. I took a little bit of a break to focus on other things that I'm working with right now, but I have Dr. Matuzsan. Did I pronounce that correctly?
You did.
Nice. I have Dr. Matuzsan here. Very interesting. Everybody is super interested in hearing the perspective of a physician, but not only a physician, also somebody that specializes in something so new and so interesting. Obviously, I've had a lot of emergency services professionals on the podcast because that readily aligns with my personal interest as well. So I think it's pretty cool to have an EMS fellow here. I'm not certain people, or I don't even think they realize EMS fellows exist, to be perfectly honest. They know there's emergency medicine physicians and their knowledge just kind of starts and ends there. So what does the path look like as far as becoming an EMS fellow goes? You don't have to go too in depth about medical school. I think everybody understands to become a doctor, you have to go to medical school. You don't have to touch on the undergraduate studies, anything like that, but you can, just a synopsis on how it is you become an EMS fellow.
Awesome. Well, first of all, thank you so much for having me on. I am a fan of the show. I've listened to the episode so far. So once again, good job on all the great things that you're talking about and the people that you're talking to who are really impressive.
Thank you. You read the script exactly like I sent it to you. No, I appreciate it. Thank you very much.
Check in the mail. No.
Yeah, exactly.
So to get to an EMS fellowship, so like you said, did 4 years of college, 4 years of medical school. Typically, people coming to an EMS fellowship have an emergency medicine background. So I did a residency, a subspecialty in emergency medicine. I did a 4-year residency, so that was my specialty training. Emergency medicine is 3 or 4 years, depending where you go and depending kind of what the program looks like.
Okay.
Time I became involved pretty heavily in pre-hospital medicine. As a resident, I was a medical director with an attending supervising doctor kind of on top to overlook everything I was doing. But I got involved with a lot of the ambulance that would bring us patients, and additionally a lot of education of the pre-hospital providers in the Lehigh Valley area where I was. I wanted to do a little bit more specialty in that, and one of the subspecialties of emergency medicine is EMS, Emergency Medical Services, which is a 1-year fellowship, basically specializing in giving an emergency physician extra training in EMS or pre-hospital medicine.
Now, is this is all building up to you? Obviously, you intend on working as an emergency physician for years to come, but is this all training with intention of becoming a medical director for these EMS agencies?
Correct. So as of now, because this is a relatively new field, emergency medicine EMS first got a board certification, which is kind of the national recognition after you finish a fellowship in 2013. So previously there were EMS fellowships. A lot of times, a lot of them got a master's of public health as part of their certificate program, but having a board certification gives an extra level of legitimacy to it. And there's only been about 7 or 8 years of that test being given.
That's phenomenal. I actually did not realize it was so new. I understand EMS is so fresh, and emergency medicine as a specialty is so fresh as well. I mean, at this point, what is it? 4 decades old, maybe a little older. But I had no idea the legitimate credentialing is so fresh.
Yeah, it's and I think it adds an extra layer of legitimacy, and it kind of makes sure that the training in pre-hospital medicine for the fellows are at least have some type of format to make sure all the core areas of pre-hospital medicine are covered. So everybody has a little bit different of a career goal, because within pre-hospital medicine, there's a lot of things you can do. You can be a medical director, but in a lot of places right now, you don't necessarily need to have a fellowship to do that. In the future, my thoughts are probably going to go towards that. since there's now kind of a growing number of pre-hospital physicians. But there's other areas in pre-hospital medicine that an EMS physician can go into. So event medicine, which with COVID right now is, there are really no large events. But the hospital that I'll be working for and where I trained actually did, they did medical direction, and they actually did medical care at a big NASCAR race. So there's event medicine like that,
Sure.
teams, concerts, all those type of things. There's actually tactical medicine also, which is under the umbrella of EMS. So a lot of times physicians will be on SWAT teams and things like that. There's the medical direction kind of side of it. There's the education component. So every paramedic or EMT course needs a medical director. Typically EMS physicians are specifically trained to do things like that. So there's kind of a whole bunch of stuff you can do with an EMS fellowship, and that year of fellowship, the fellowship is a year, kind of gives you the tools to be an expert in that level that otherwise you might not be an expert in.
That's amazing, because there's obviously so many different fields of medicine that you can pursue as far as residencies go, and the specialties are pretty expansive. But I didn't realize that there's so many umbrellas underneath of the fellowship, which is pushing your specialty even farther. Now can you hyper focus on one of those specialties within EMS fellowship, your EMS fellowship, or
you can? Yeah, there's a lot of opportunities to kind of focus in on what you're specifically interested in, and every fellowship is a little bit different in terms of what they tend to like. So the reason I'm doing the fellowship in Camden, New Jersey right now is because there's a lot of physician field time, meaning that I have a vehicle and I can actually respond to 911 calls with the paramedics, with the EMTs, to be another set of hands, or if there are difficult situations, to be an on-site medical director, which just makes things a little bit easier than having
so much easier
EMTs call in to the radio, because obviously the emergency medicine docs in the hospital aren't on scene and can't really see the whole situation.
Yeah, you get to piece the entire puzzle together, and you get a firsthand view of it, which is certainly a unique position to be in, because quite often, whether it's a lapse in communication or, the person who's trying to communicate what they're seeing, the paramedic may be socially inept, or they're just, stressed out with what it is they're encountering. That's actually a beautiful thing, to cut out the middleman and just have that immediate on scene command, somebody who is the highest trained medical authority, to be able to just appropriately delegate interventions and say, here's what we got, and now I have a better view of it. And you kind of get to step in their shoes as well and walk in their shoes and see the entire puzzle. That's kind of cool.
Absolutely. And medicine in the field is incredibly different than in the emergency room. It's almost, I know towards the beginning of my fellowship right now, I'm about 9-10 months in at this point. There's a whole different variables kind of in the field, a whole different dynamic with, family there than in the emergency room. It's a different brand of medicine. And that's why I really think the year of fellowship, at least in my opinion, is valuable, because you're learning to kind of balance a lot of those other factors in the field. And a lot of times you don't have as many hands, you don't have as much information. And in the emergency department, we a lot of times encounter those same variables, but it's to a different extent in the field.
Is there a phrase, would you call it obviously it's not dirty medicine, but we call it street medicine or whatever, where you're just working with limited tools in a, relatively austere environment?
No, absolutely. And I mean, extrication of patients from various situations, dealing with, crowds, dealing with dynamic situations. We do in the emergency department, but in the emergency department, we also have some of the tools to make it a little bit more controlled than sometimes in the field.
You know what? That's interesting you brought that up, because when I interviewed Astro, one of the things he touched on, my very first interview, one of the things he touched on is the stresses of not only, responding to a call where tensions are high and you truly are at the mercy of the information a bystander or family member can give you, but it is the worst day of their life, their family's life, whatever, and they're screaming. They're so stressed out. They cannot understand why it is you're moving at the pace that you're moving. And sometimes you don't understand. And when I say you, I mean, sometimes hospital personnel do not understand why prioritization has to be placed on safe extrication from those environments as opposed to life-saving intervention, which sounds ridiculous, but you have to maintain your own safety remove them, and now you can prioritize what interventions you're going to do and whether or not proximity to the hospitals in their favor, and it becomes like a delicate balance. And that's kind of cool that you get to witness that. Not many people do.
No, absolutely. And a lot of times those type of decisions, like you just talked about, balancing, do I just, rush to the hospital? Do I kind of, stay and do some life-saving interventions? The interventions themselves are skills that typically can be taught, but some of the higher level thinking that the paramedics and EMTs have to do, that's almost what is the most difficult part of the job, and kind of being there as an extra, set of hands and, somebody that can help kind of weigh in on that, I think has a lot of value.
Do you have a background in EMS?
I do. So I thought it actually goes back to 2007 when I was still in high school.
Okay.
I thought I might be interested in going to med school, and my and this is when I was still in high school, and my dad said, "How about you hop on an ambulance?" And as a high school kid, I said, "Absolutely not. It's not happening." So I joined the local rescue squad about a week later, and loved it. The first day I was there.
Yeah.
And became an EMT shortly after, and then did EMS in college. I met my wife doing EMS in college, actually. Worked at Six Flags as an EMT, which was a very unique and fun way to spend a couple of summers. And I was actually still volunteering in New Jersey at my hometown squad where I first started, even throughout medical school.
I find so many people catch the quote unquote bug when they get their toes wet and they work in some facet of emergency medicine, whether it be EMT, paramedic, some other emergency service. They usually, if med school is the path, they more often than not, I will see they get the bug. They truly like that environment, and they try to translate that in the hospital setting as well when they go on to an emergency medicine residency or EMS fellowship. So is that background in EMS mandatory for the fellowship, or does it just help the cause when you're interviewing?
Yeah, it definitely is not. It definitely is not mandatory to have an EMS background. Last year's fellow did not, and one of next year's fellows does not necessarily either. It definitely does help though when interviewing for these positions, because you kind of know it's not only interviewing with the fellowship director, but typically you interview with the EMS supervisors also. Because you spend a lot of time with a lot of these people, with the paramedics, the EMTs, in addition to the medical direction, the physician team too. So it definitely helps to kind of know the lingo, kind of know how things work already. And also it helps when you're on scene, when you're familiar with some of the pieces of equipment that are just not taught in an emergency medicine residency.
Sure.
Moving is not necessarily taught. Even some of the other kind of skills, the various monitors that we use in the field are not part of the day in, day out skills that are typically taught in emergency medicine residency. So I think it definitely I felt like it really helped me a lot.
And I'm sure you've been witness to this since you have a background in EMS, no matter how light or infrequent it was in college, but you saw how different systems operate. So I feel like that's probably important going from suburban Philadelphian region to Camden City, New Jersey. I'm sure things are vastly different. So it seems extremely valuable to get some perspective from the people that are on the street. So that makes sense. Absolutely. So you have a background in EMS. And this is probably a stupid question, but I have to get it out of the way. Do all EMS fellows come from Em Residencies? Because I can't imagine another residency pursuing an EMS fellowship.
Yeah, for all intents and purposes, yes. There are some very few exceptions. It's typically if somebody who does pediatric emergency medicine also has an interest in EMS. There's some ways kind of around it, but in general, it's considered a subspecialty of emergency medicine. So pretty much almost across the board, yes. If it's emergency physicians, you have to do an emergency medicine residency.
Yeah, it would seem nonsensical otherwise, coming from a different specialty but
that being said, there's a little bit of, I guess, a nuance that some states recognize pre-hospital physicians and others don't. Meaning that in the state of Pennsylvania, there's actually a pre-hospital physician license that you can get through the Department of Health, just as a paramedic does and an EMT does. New Jersey doesn't necessarily have that, and you don't necessarily have to be an emergency medicine doc to get that certification, at least in the state of Pennsylvania. But they recognize if you do that's nationally recognized because you'll be board certified by the national organization.
And that,
but New Jersey, just in the field, there's no physician pre-hospital certification. We operate in New Jersey under our own medical license, which is through the state, but not specifically for pre-hospital.
Sure. And I'm going to do a name drop real quick, but now that you mention it, in 2012, I remember a medical director that I was speaking with, Dr. Jaslow, was really, really keen on working in the pre-hospital setting. And I know he was a medical director for several squads, Dr. David Jaslow. I don't know if he's still practicing, but I did not realize while I was learning about it and pre-hospital physicians, it was still so new because this was pre-2013. So that's actually...
It's still pretty unusual to have docs in the field, which is, we're in the South Jersey kind of area. It happens a lot, but across the country, by and large, it's pretty rare to have a doc in the field kind of helping out and doing things.
Yeah. And when you came to Camden City, was there anything you had to change in your practice as far as functioning as a physician in the emergency department, or is it basically par for the course and you just business as usual in the ED?
Yeah, so it's definitely a little bit of I trained up in the Lehigh Valley, so we had a little bit of a different patient population overall than in inner city, a pure inner city than Camden. And even as part of fellowship, I usually work as an attending ED physician in the emergency department about once a week or so, depending on the week and the schedule and things like that. Definitely in Camden, substance abuse is a huge problem. Opioid epidemic is still kind of raging on. I would say I've seen definitely more opioid overdoses than where I had practiced previously. So it does change your practice a little bit in terms of kind of workflow and things like that. It's stuff that I've been exposed to before, but it's just a little bit different system, a little bit different patient population. We do have a decent, a really good social work team too, because a lot of the issues that we see in the emergency department are, they all have social, problems in terms of housing, in terms of food, in terms of figuring out kind of where to go after the emergency department and follow up. So kind of integrating that a little bit more into my ED practice and having some of those resources. But a lot of times it's difficult, and our goal is to try to connect patients as best as they can with the resources they need.
Sure. I think
Oh, sorry, go ahead.
No, yeah, sorry to cut you off. I was going to say, I think there's a lot of value in having that more well-rounded view and get kind of an experience from different eclectic backgrounds and areas and demographics. And I don't know, obviously you said in the ED in Lehigh Valley, it's a little bit different as far as emergency department visitors go and demographic, but I'm sure the operations within the hospital and cohesion and challenges faced and everything else is probably slightly different as well. And I just think there's probably a lot of value in seeing the different environment, both out of the hospital, pre-hospital, and in the hospital itself too. Now,
absolutely.
Was there an option? Real quick, was there an option in the Lehigh Valley to do an EMS fellowship? I'm not sure. What is their program?
There's not actually right now.
Okay.
Previously, kind of before 2013, there was, but currently right now there's not. And there's kind of there's undergoing an expansion right now of EMS fellows and fellowships, just because as the more EMS fellows that get trained and go into practice, it's becoming a little bit more prevalent. There's some new programs kind of opening up across the country, which I think is a good thing for the subspecialty.
Yeah, for sure. What did I cut you off saying? I'm sorry. I know you were starting on
about the emergency department. And I guess the other thing that I was going to comment, specifically the link between the pre-hospital environment and the emergency department, is one thing that I didn't realize that I think we do well in Camden, I'm getting a really good experience with, is addiction medicine in the field as a pre-hospital function. Which is not the standard across the country, but the medics specifically in Camden are trained after opioid overdoses in motivational interviewing and actually to treat addiction and treat withdrawal symptoms with various medications, and then link those patients to the addiction center. There's kind of a nice tie between the emergency department pre-hospital addiction problem, and then the addiction center. And it's something that I'm getting a good experience with, and I think is a little bit unique. And it's nice to be able to kind of serve as that, help serve as a link between the ED, the patients with overdoses that we specifically see, treat, and then kind of refer them to the addiction center.
It almost seems like a subspecialty within community paramedicine. It's like, it's a form of public outreach, and it's, obviously it's not the typical interactions that they have with paramedics. So you're right. That is pretty unique. I don't see anywhere else really going around and utilizing those same skills.
Yeah, but I think that's also kind of the cool thing about being an EMS physician is those opportunities that you can kind of help bring from. Typically, we treat patients who have an opioid overdose. They get naloxone, the reversal agent. They go into withdrawal because of that. We typically will treat that in the emergency department, but a lot of those patients don't want to come to the emergency department. So the problem was identified years ago, and we brought the treatment out to the field. And I think that's one of the things that an EMS physician can help do. Maybe not that specific problem, whatever problem your patient population is facing, but you have kind of the tools to help kind of merge the treatment and work with the medics and EMTs and work with the patients out in the field to solve those type of problems.
For sure. And just to quickly touch on it, it sounds like there is everywhere else, not just Camden City, a large push for medication-assisted treatment, right, in terms of treating addiction?
Correct. A lot of the data shows that medication-assisted therapy is really the way to go in terms of keeping people sober, keeping people clean for longer periods of time. And honestly, this actually came from one of the medics. They said, hey, they tell their patients that they see when they're talking about medication-assisted therapy for specifically opioids. They say you have high blood pressure, you treat it with the medication. You have diabetes, treat it with the medication. You have an opioid addiction, we have a medication to treat it for. We treat it the same way. And honestly, that's where kind of the light bulb goes off for a lot of those patients. And the medics and EMTs have a lot of they initially, I think a lot of people were resistant to it, and then they see their patients get better. They see the impact that they're having on their lives, and a lot of the medics and EMTs absolutely love treating addiction in the field. They talk about it like it's one of the better things that they do.
Sure, it's a unique opportunity within EMS to have your care and the result of your intervention extend beyond that brief window where you're just quote unquote treating them and treating them. You got them for 15 minutes, you stabilize, you drop them off at the hospital, and then you never see them again. So this is a unique opportunity where you get immediate follow-up and you get to see what it is that you did and the impact that it had. So you're right, there's a lot of reward in that.
Absolutely.
Now, as far as the EMS fellowship goes, when you're finished, you said it was a year-long fellowship?
Correct. And they're all pretty much a year at this point.
Okay. And you're almost done, right? You're wrapping up?
Yeah, we got a couple more months.
Yeah, a couple more months.
End of June.
When you're finished, is this going to give, for all the aspiring physicians that think, I'm interested in EM, I want to pursue an EMS fellowship, will this give you a competitive edge or some sort of upward mobility within the hospital system or whichever hospital you decide to work for?
Yeah, absolutely. It does. And I think that's honestly the reason I was hired to go back to the Lehigh Valley area. This has been a tough year with COVID, that there's actually not as many emergency medicine jobs as there used to be. Honestly, it's hard to find a job right now. Before COVID, jobs were almost a dime a dozen, and you had a lot of options. Now, you don't necessarily have a lot of options. So it definitely helped me get a job, because I'm not only coming back as an emergency physician, but I have a subspecialty also. And I'm going to be involved with the residency up there, which kind of diversifies the residency faculty. And I'll be involved with some medical direction and some EMS education. And that's kind of what actually helped me land the job. So I think it does give you a lot of options. And I'm going back to an EMS system that they do medical direction for a helicopter system. They have their own EMS Education Institute. So there's a lot of kind of mobility from having that extra level of specialization. Yeah.
And one of the things that comes to mind, and, I witnessed this firsthand. A lot of people working in the emergency department have a high rate, maybe not a high rate of burnout. I'm sure it's a high rate of burnout, but they definitely get drowned in all of the stresses that come along with working in emergency medicine. So this seems like a pretty good opportunity to step away from that and get some breathing room, quote unquote, and maybe some outside the ED experiences. Do you think that's one of the benefits that comes with it?
100% agree. I mean, we know, like you just said, we know that there's a high rate of burnout, and if you do straight clinical shifts in the emergency department, that's kind of a known fact. It's been true for several years. So I think in terms of longevity, if you can kind of have another outlet, another niche, another something that you can get some time for and put some time and effort into. Whether it be pre-hospital medicine, whether it be, I have friends that have done toxicology training to not only work in the emergency department, but be a toxicologist on top of that. Education, there's a whole bunch of things. You can be an expert in ultrasound or even specialize in pediatrics on top of emergency medicine. I think in terms of longevity and preventing career burnout, that was one of the reasons that I decided to do a fellowship. You end up doing a year. You definitely get paid less as a fellow than you do as an attending, where you can work as an attending after you complete residency. But I think I'm going to be able to extend my career another couple of years on the back end.
Yeah, for sure. You get a break, because I know there's listeners in Europe, and we actually the podcast is now being listened to in Asia as well. I don't think they truly understand there's a wildly different health system in every different country. I mean, one of the surgeons that I'm going to have on here, she's from Barcelona, and that's where she's practicing in Spain. And I don't think people understand just how physically and mentally abusive an emergency department in a major metropolitan area in America can be. It's no walk in the park. People will say that it's controlled while compared to pre-hospital environments, like in Camden City, like you said. But, you walk into the emergency department at any given time, there's people screaming, there's people throwing things, there's people, mistreating healthcare workers. So it's definitely, it seems like a good out from that. I mean, granted, you're throwing yourself back into an austere environment going outside of it, but like you said, you have these outlets, these other areas, education and working with the EMS agencies in terms of implementing protocols or the best protocols or practices. So it makes sense in my mind. Now, one of the questions I have is, you go to medical school and you already have this massive commitment of time, massive commitment of money, and you get into residency, and I'm sure it varies everywhere else. You have this, you have this 3-4 year long commitment, whatever it is that you're specializing in, whatever they require, where you're probably working a lot and not making as much money as you should. Now, do you ever have self-doubt when you pursue a fellowship that, well, I'm just extending that that abusive relationship with, here's my mountain of debt and here's my income. And, obviously it eventually levels out. And if you're committed to a life in medicine, that's just a secondhand thought. But it would certainly plague my mind. Like, this is super interesting, but like, what's the cost versus benefit kind of deal?
Oh, no, I think that's a solid question. And before I even started applying to fellowships, that's a question that I had answered to both myself. When I was talking to the faculty of where I did residency, that's one of the questions they had too. The question is, what are you going to do with this? Is this a year that you're just, not going to be making as much as you can just because you want to? And then I think the most important person I had the conversation with was my wife, because we had been together since I was even a pre-med. And, I talked with her and I said, at this point, and this whole conversation is going on when I was applying in the context of my wife being pregnant with twins. So I'm applying, to fellowships after finishing during my last year of my residency. And I've been talking about EMS stuff for years, pretty much the entire time that we were together. I mean, we met doing EMS. We literally were handing a bag and a radio off the freshman year of college to each other. So she completely gets it. And she said, you know what, you come this far, It's what you want to do. It's going to extend your career on the backside. This is, something feasible to do. You should go for it. So she, kind of a combination of all those things and everything we've talked about. It is an extra year. It is an extra year of training. But at the same time, if it's something that you're passionate about and something that you want to do, it was kind of a no-brainer once I was able to answer that question. And, my wife was on board with it too, because she kind of understood that. And, but it's definitely stressful. It's definitely a question you have to answer. It's not an easy question.
Yeah. As long as you're not spiraling into like an existential crisis about it, then that's great. It sounds like you have a, good line of communication with your family and that I'm sure made things easier as far as your decision goes. But
yeah, and I had a good setup in terms of where I'm at now in Camden, where I didn't actually have to move from where I'm at. I drive a little bit. I have a 50-minute commute, which is not awful. It's very doable for a year. So it everything fell into place as it should.
Awesome. What area of EM in particular, or I guess your EMS fellowship, you mentioned all of those subspecialties within that fellowship. What area interests you most? Because you're kind of spreading your wings out and you're touching on several different things. What do you like most?
I really enjoy the education component, to be honest with you. I've been teaching an EMT class even when I was a resident for a long time. Actually, probably every other week we'll stop by a current EMT class in Cherry Hill, where we also do medical direction, just to say hi. Last time I stopped there a couple of days ago, ended up giving a cardiology lecture for about 10, 15 minutes, just kind of, off the top of my head. An evaluator for the National Registry Paramedic exam last couple of years. Do a lot of refresher lectures for them. So that's probably one of my areas of most interest, the EMS education component.
I could not agree more. I find so much value in teaching, because this career in medicine is obviously you committing yourself to being a lifelong academic. It's ever evolving. So by nature, you have to constantly refresh. And, I just have a very small sample size of when I was tutoring undergraduate science courses. I found so much value in not only retaining the information myself, but there was like a sense of fulfillment, because I can learn something to regurgitate it, but whether or not I comprehend the concept is an entirely different thing. So when I am feeding this information, quote unquote, teaching it to people that are learning it, I'm also just refreshing it myself, and I'm staying on top of it myself. So I could not agree more. That seems like such a cool thing to have your hand in as far as your EMS fellowship goes.
Yeah, no, I love it. And the other thing I like to do is I sometimes try to go to calls with newer providers for kind of that same reason, because it's not just that education in the classroom, but then it translates to the actual field and some of the subtle things. And there's a lot of good teaching points in the field. I had an EMT student with me that we went to a call that ended up what we thought was more of an older person with change in mental status, maybe some psychiatric illness in there. But her vital signs, her oxygen level is 85%. She's talking to us. She's saying she doesn't want to go to the hospital. There's definitely some psychiatric component. But in the era of COVID, when your pulse ox, your oxygen level is 85%, what turned out to be, a COVID patient, as opposed to just an altered mental status patient with plus or minus psych condition, that was a great kind of teaching point, and almost has another element of, that student's not going to forget that, call. Because there was a lot of discussion with the family and stuff like that. It's tough to teach that in a classroom setting.
Now, if you are comfortable answering it, what do you think EMS is lacking most? Emergency medical services, the paramedics and EMTs. Where do you find them falling short the most? And I know you have experience both in Lehigh Valley and Camden City, but where do you think there's the room for most improvement?
Yeah, tough question. I think sometimes some of the new literature takes a while to get into practice, and that's not necessarily unique to EMS. That's kind of a whole medicine problem in general. But there's been a couple of really good pre-hospital studies that came out over the last couple of years. Things like airway management in patients in cardiac arrest, things like what medications typically work in those critical patients, things like who should we give special medications to for trauma patients. And I think some of that could have pretty quick impact and almost be practice changing. But every state kind of regulates how they do EMS. It's a very state-run thing. So there's not a big unified protocol that everybody kind of follows. A lot of it is state-specific. There are some national guidelines, and there's some national organizations that do a really good job at those guidelines. But sometimes the newer research that is good research, that it can be practice-changing, that can be implemented here and now, sometimes takes a little while to get into practice, and then re-educating everybody or sending in that bulletin is tough to get into practice sometimes.
I'm going to give you a non-diplomatic answer, and you do not have to comment on it whatsoever, but I want to vent, and maybe this is a system-wide issue, but I find two issues in EMS. I find lack of humility, and maybe that's just a medicine thing, but there truly is no room for ego in something that's supposed to be so collaborative and just open forum discussions. So I find lack of humility being a serious issue pretty much everywhere you go, even in different countries. When I was in Sweden, I got to briefly interact with the pre-hospital paramedics and nurses in Stockholm, and they agreed. They said the same thing. There's definitely a lot of egos in medicine, and also maybe complacency is not the right word, but I find a lot of people get too comfortable in what they know. They've learned, they've passed the test, they've become a provider, and then they never push themselves beyond it, whether it be refreshing content, learning new information, and just kind of coming to terms with the fact that, like I said previously, it's ever evolving. So they got the job pays, and now they're, A plus B equals C, and that's going to be the rest of my life as far as a pre-hospital provider goes. And I don't think that's a good place to be. I always say, I don't know if it's an old adage, but I always say, seniority does not necessarily equate to competency. You can do a job for 30 years with, your first year of experience multiplied times 30. So I think there's definitely a lack of people pushing themselves to learn more and to get better and to learn evidence-based medicine. And I think that's where you guys could probably come in and definitely push, journal clubs, educational seminars, stuff like that.
I 100% agree. I think one of the toughest things one of the hardest conversations as a medical director and a fellow that we have is asking, when a call either went poorly or maybe it went well, but we just didn't know the decision process. And the answer is because this is how we've always done it. That kind of exemplifies everything you just talked about: complacency, maybe not, reading up or being fresh on your skills and just kind of, skating by. And it's not necessarily just unique to the pre-hospital environment. It can happen in emergency medicine too. There are providers that get a little complacent, maybe aren't as up on the literature as they should be. Maybe don't do those extra, seminars or learning experiences. But it definitely is prevalent in EMS. It's one of the big challenges. And I think that's another area where like you said, the medical directors, the fellows, the physicians that are involved in pre-hospital medicine, that's an opportunity for education. That's an opportunity to try to push everybody in the right direction and try to intervene when there's some outdated practices happening.
Now, let me touch on what you just said, because now you have this shitty situation where, I mentioned it previously, humility is lacking. You have to broach this QA situation or this open forum discussion, and you have to sound diplomatic about it. But what you're trying to do is educate them on why they were so grossly wrong. Do you ever find that people, and this doesn't have to just be EMS, do you ever find people see physician and they see you approaching and they think it's immediately a challenge, a standoff, rather than, an educational discussion?
Oh, sure. I mean, it happens all the time. I know we talked a lot about like field response and some of the other things we do, but I would say a lot of my time is more administrative, also meaning reviewing call sheets and the documentation from various 911 calls that we do on a monthly basis, and have like big meetings, whole day meetings kind of about. And you put what's called a little flag onto these charts that says whatever you want it to say. Hey, why did you do X, Y, Z? Or did you think about this? Do you think about that? And there are some providers that will, answer and say, oh, I will consider that for next time. Thanks. There are other people that say, I'm going to come find you in person and let's talk about this. And there's some people that the message doesn't quite land if it's something that I thought should have been different. And that's part of, I think it's one of the challenges. It's knowing how to be confrontational without being confrontational, and how to diplomatically, say things that, hey, this should have been done differently, or this could have been improved. There are different things that we look at, and that's probably one of the challenges, probably the biggest challenges of being an EMS physician, and learning, doing medical direction and things like that, trying to balance not being that confrontational, but educating, because we still want these people to be giving optimal care to their patients. And a majority of the time there's no problem, but and a lot of people are really receptive and appreciate having a physician like looking at everything and trying to make them, better, because that's what we want. We want everybody to be better. And it's never, in general, when we flag a chart, it's not punitive. It's, we a lot of times don't understand the circumstances that the decisions were made, because we weren't there, and all we're going off of is a chart. And if there are other circumstances that they didn't document, we just want to kind of know about that, and have another viewpoint of it.
This is why the fellowship's so good, because there are people, it's so new. There are people that are still working and have been working for 30 years as an EMT or a paramedic. And for whatever reason, it is burned into their mind that if the medical director is approaching you, there's this dark, ominous music, and you're about to be challenged on something that you did incorrectly, when realistically, like you said, it's just supposed to be like an open forum discussion, and you're supposed to, go back and forth and maybe learn something from each other, or maybe they learn something, or, see it from another angle. And I don't know, why do you think that is? Why do you think there's like such a fear, maybe not a fear, but just this like.
Well, I think it's because the cadre of like EMS trained physicians is still building. So not everybody's medical director is an EMS trained physician. A lot of places their medical director is an emergency medicine doc who didn't specifically train in pre-hospital medicine, but's been the medical director for forever there. And sometimes the only interaction they'll have with that medical director is when they mess something up. So it kind of flags it. They get a flag, or they get an email saying you need to talk to me from the medical director. It's never necessarily a good thing. Sometimes it's always a bad thing. And I think that's kind of where a lot of it kind of comes from, depending where you work, depending how you've interacted with your medical director, depending how your medical director has been either present or not present in kind of either day-to-day operations, or how active they are with the QA process. Because if the only time you're interacting with your medical director when there's a problem, or there's something that didn't go 100% as it should have, that dynamic is just a negative dynamic right off the bat.
This is where the fellowship's so good. You're bridging the gap. Like there is, there's this long-standing idea, like we've talked about before, where people are afraid of being called in and spoken to about something that they did. But now with EMS fellows, you're training, you're in the field, and you're able to kind of show them, hey, I'm here to learn, you're here to learn, let's work together. Like this is not meant to be toxic. This is not meant to be me reigning over you with my superiority, or it's not a situation like that.
That's the goal of the EMS fellows, that when you graduate fellowship and whatever job you take, wherever it is, that you're a presence in the pre-hospital community. They know who you are. You're somebody that they can also talk to, and if they have questions, if they need, some maybe continuing education class or kind of whatever it is, you want to be a presence. I mean, when I was a resident and kind of got involved with some of the local EMS organizations where I was having providers like send me cases, Some would say, hey, I'm not sure this case went as well as it should have. Can you take a look and give me some feedback? And that's what I think would be ideal, as opposed to me kind of looking through the charts at the end of the month and finding something that wasn't that didn't maybe it was a little questionable. They brought it to me right up front.
And you know what? This is where you have a great opportunity to just show face. One of the job duties, one of the parts of your fellowship, you can literally make a difference just by hanging out at the station and being there and being a presence, like you said. That's pretty cool.
Yeah, it's absentee medical director is it happens at a lot of places, but I think the way kind of the future is to be involved, because at the end of the day, the pre-hospital personnel are bringing patients to the emergency department. Even if there's your time, I know everybody's time is limited, but I would have, whenever EMTs, medics, when I was in training in residency, or even now, if I'm working in the ED and they bring something in. That I know I'm getting either CAT scan on or some blood work and stuff like that. I'd be like, hey, when you come back later, and we always make a joke about, hopefully you don't have to, come back later. Come see me and I'll show you whatever CAT scan, whatever, the blood work and things like that are. So even if that's kind of the FaceTime, because everybody's time is limited, it's kind of, trying to make a seamless process between the pre-hospital, the ED, and then eventually the hospital. And I had a bunch of EMT and medics kind of take me up on that. They'll come back and find me in the ED. They're like, hey, that patient we brought in an hour or two ago, we find anything? And a lot of times I'll be able to pull up like a CAT scan or X-ray and kind of show them. And that's kind of all about the relationship building, which I think is probably one of the most difficult parts about a pre-hospital position in the fellowship. It's the relationship building. And it's learning how to deal with various difficult situations in terms of if you have to do any remediation, if you have to, still, you're all on the same page. You're all on the same team kind of at the end of the day. So, that's one of the more difficult parts, I think.
There's just so many conflicting personalities too, and just so many strong personalities in emergency medicine, I find. But when you give that follow-up, you're probably building a stronger provider, because how often do they just drop off a patient and they don't know what happened to them? But now that they have the education of, okay, I saw XYZ, I can better develop my differential diagnosis in the field based off of prior experience, because now I know what to look for. Now I know what happened to them.
Exactly. And I think the other thing that we do too is we not only interact with the pre-hospital personnel, but a lot of times we have ED providers, whether it be residents in the ED or attendants in the ED, say, hey, I got this call on the radio from EMS. They were asking to do XYZ. I'm a little concerned or confused or something. They had some concern in the field, and we kind of can do a little bit of investigation. We can listen to the call. We can talk to the EMTs or medics, and we can go back to the ED docs and be like, this is kind of the whole situation. Here's the surrounding facts. So we serve as almost a liaison to the rest of the emergency department whenever they have concerns and questions. And more often than not, there's some piece of the puzzle that they didn't know about, or the scene was a little more dynamic and things like that. So we're kind of in between the pre-hospital and the ED providers also.
It's awesome. That's a great relationship to build. Like you said, both bridging the gap between EMS personnel and the EM personnel, the people in the department, and then also, like you said, medical directors and EMS personnel. Really cool. Now,
the ED actually will even sometimes, after they get off of the radio, when talking to EMS, they'll call one of us and be like, hey, are one of you guys around? It sounds like there's a difficult call going on. If you can both help out us doing some, talking with the medics radio, or even if you're available to go out to the scene, we have that happen not infrequently.
That's huge. I you know what? That reminds me, people don't understand how many parts of the world have physicians cycling around in pre-hospital environments. One of the primary examples that I remember, there was an article written in some emergency medicine magazine. I forget, years back, there was a terrorist attack on a concert hall in France. I forget exactly where in France. There was an Eagles of Death Metal concert, and there was a terrorist attack. People with AKs shooting a bunch of people in the concert crowd, and all of these images were cycling of pre-hospital physicians. They're and same thing in England. There's pre-hospital physicians everywhere, and that's like what a good tool to have. Not to call you a tool, but what a good resource to have. Yeah, like what a good resource to have readily available. Like, why wouldn't you want that? It makes complete sense to have, you know, the highest level of emergency medical care available.
It's interesting that it's interesting you bring that up. There's really two big schools kind of thought and systems in terms of pre-hospital physicians. The Franco-German models is kind of what you're talking about, meaning there's a lot of pre-hospital physicians and docs in the field, specifically France and Germany, who kind of pioneered that model. And then there's the American English model, where in England it's probably a little more prevalent, but in the US it's not as common to have physicians out in the field. In the Franco-German model, a lot of those physicians will go out and make a determination whether the patient goes to the hospital or not. That's kind of considered accepted practice. We don't necessarily do that in the U.S. There's a whole different medical legal system, a whole different kind of structure, but it definitely is a little bit different in different parts of the world. Sometimes physicians are a little more prevalent in the pre-hospital environment. Some of these ambulances and the helicopters abroad are even staffed by an anesthesiologist, an ER doc, and that's kind of what's normal for them. So it's very different around the world, which is interesting to see.
You know what? You should petition for a field trip for all of the EMS fellows. Have a company-funded trip to somewhere in Europe to see their model of pre-hospital physicians. That would actually be kind of cool.
Absolutely amazing if we were allowed to travel now.
Yeah, that would be actually really, really cool. Now, you touched on challenges. I don't want to hold you up too long, but I do have a million questions. But you touched on challenges as far as being an EMS fellow and a medical director. What are some big challenges that you face in the emergency department? The flip side, what are some things that are really difficult to deal with or cope with? And if you want to be toxic for a minute, I can also always edit it out. I can always cut it out if you get a little too heavy on the vent. But no, I mean, feel free to touch on anything that really is bothersome.
Like you're talking about when I work in the emergency department, you mean?
Yeah, challenges within the department itself, because a lot of what we talked about and the challenges that you're facing over the last probably half hour, the challenges we were talking about, mostly aligned with you as a fellow or you as a medical director. But what about when you are Dr. Matuzsan in the emergency department, not out running around doing all of the things that you do as a fellow?
Yeah, I mean, it's busy in the emergency department. I would say a majority of my shifts, almost overwhelmingly so. So I think one of the most difficult things is you gotta make sure you take the time with each patient. But when there's a million patients to be seen, and you're kind of always getting pulled in one direction or the other, it can be tough. You don't want to miss anything. Is one of the big challenges. One thing it's tough for me to be too negative, because I do like my job. I do like
of course,
department and all of that. I really do love working with the residents though at the hospital I'm at now, which is great. They definitely make your life a lot easier, and that makes the shifts go by relatively quickly. I mean, we are in an inner city. We see a lot of substance abuse, which sometimes you'll see a majority of patients your shift may be substance related. But at the same time, that gives you the opportunity to try to really impact somebody's life and kind of turn it around. And, a lot of times you'll see the same patient again, day after day after day. But that's part of the job. And it's, hopefully maybe the next time you offer them rehab, they'll accept it and something will change. And we do see a lot of psych patients also, which that doesn't get tiring per se, but it's something that really, it kind of just exemplifies how broken of a mental health system that we have, and how really there can be a lot of improvement really across the board, not unique to Camden by any stretch. It's almost a whole country issue. It's been tough with COVID also. I know in your previous podcasts, you always ask about it, how it's it's a game changer in terms of things that it's a whole different way. We can't, you can't even eat at your workstation anymore. Usually in the ED, you're multitasking. If you're going to have a meal, in between, it's a 9-hour shift. A lot of times you're there extra long. It's tough to leave the emergency department to go to a separate area and do that. So all in all, I can't rail in working in the ED too much. I do like doing it every time I have a shift. I love working in the pre-hospital environment, but there are times where it's time to go back to the emergency room and kind of work clinically. And it's a nice balance between ER and pre-hospital medicine.
Yeah, and you know what, I probably could have phrased that better. I didn't want you to say like, oh, the attendings I had to train under were assholes or anything. I wasn't looking for that. Just like challenges that are faced. And I think you touched on that beautifully, because I don't think many people realize how often the emergency department is utilized as this primary care center. It's a one-stop shop for whatever acute, life-threatening or completely benign could have been seen at an urgent care ailment. So you are in my mind, emergency medicine physicians are the kings and queens of resuscitation. That is what they specialize in. They're great at high acuity, rapid triage, appropriate allocation of resources. And now you have, two people that you need to RSI that are really sick with COVID, and they're going to, end up on ECMO. And you have somebody else that just coded in another room. But now, like you said, you also have 4 psychs in another area of the hospital and one person who's in for their 19th overdose that week. And I don't know. Yeah, I could see that definitely being a little tolling to shift gears that quickly. It's like going from 4th gear down to 1st in one swooping motion.
Yeah, no, a lot of times it's tough when you're with a sick patient. You might spend an hour in that room, but when you come out, those patients haven't gone anywhere. They're just kind of building up, and there's another million patients to see, and you just got to make sure that you're seeing them safely, that you're not trying to go too fast and then missing something too. And that's part of the challenge. Honestly, I would say in the emergency department, it's almost counterintuitive that the sickest patients are sometimes the easier ones. And the reason is we get trained very well on resuscitation. Those patients, typically, they need procedures. They're getting admitted to the hospital. We kind of know what to do with them. Some of the ones that maybe have a little bit more of a vague complaint, like generalized weakness, dizziness, that can be either something really benign or life-threatening or somewhere in between. And sometimes parsing that out is actually harder than these patients that need active resuscitation, because who can go home, who should not go home, who has that subtle finding, or maybe that one thing they said in their history that puts them from low risk to high risk. So sometimes that's even a little bit more hard than some of the other really sick patients.
So then you have to shift from badass resuscitation doctor to Dr. House, right? You get your cane out and you walk with a limp and like run through all of these tests. I just know that it's never lupus. If I've learned anything from House, it's never lupus.
Until it is.
Yeah. But that's super interesting. I think you explained that beautifully, because when I see repeat customers constantly cycling through the emergency department, I think it extends beyond EMS and the EMS fellows. It's the emergency department that has to deal with them for hours on end sometimes, and that can be grueling. You have to learn and use communication tactics you never thought you would have to use. And these, you think, I'm an emergency physician, I get to do cool, sexy resuscitations and have these high acuity cases, but now you find yourself using things that you probably learned from being a parent, talking to a 2-year-old.
Pretty much. And the thing that actually really scares me in the emergency department is we have a lot of people, like we talked about, coming in that are either intoxicated, overdosed, very agitated, and a lot of times we have to give them medication so they calm down and they're not violent. They're not violent towards themselves. They're not going to harm anybody else. What really scares me, though, because there are case reports all throughout there, is that person who, say they drank a lot of alcohol. Are they agitated because they drank alcohol, or are they agitated because they drank alcohol, fell, and actually had a head bleed? And now I'm going to just give them medication to calm them down and then miss something completely. So those patients actually spend a little bit extra time with and make sure that I loop back and make sure that they're improving like they should, because those can slip through the cracks. And we have so many people that come in agitated that from substance abuse, that it's very easy to miss something, catastrophic if you're not really closely watching. And just with the volume, they can slip through the system very easily. So that's almost one of the biggest things that scare me.
Yeah, that's like the just that black ominous cloud hovering over your head saying, hey, have you checked on that person that was, restrained and giving ketamine for their agitation? Have we checked on them in the last half hour?
99+% of the time, it's intoxicated.
Yeah.
That's almost what we're trained for. We're trained for that 1%. And that's the big, thing you don't want to miss.
So you mentioned COVID, and I always ask my guests, COVID, has it, I don't think I have to ask whether or not it's affected you in the emergency department or as an EMS fellow, because it so obviously has. But what have you noticed change most in recent times? There's been, waves. There's been, a taper off. There's been probably a shift in acuity in terms of patients coming to see you in the emergency department. What have you noticed change most recently?
It seems like we're on a good trajectory. A lot of times we do some medical direction for one of the counties outside of Camden, and they have a big mega vaccine site. And I visited it probably 2-3 times since we have a couple of crews, EMTs that are doing standbys there. And it's awesome to see that they're putting, 5,000-6,000 people a day, getting them vaccinated. And their EMS is also going out to people's houses that really have limited mobility and doing vaccinations in their homes. And stuff like that is really inspiring to see. And I think we're moving in the right direction, especially with vaccinations. It's been a very kind of unique year of fellowship because we don't have those mass gatherings. We don't have concerts going on, sports events, or anything like that. But I think COVID is still around. We actually recently, in the past week or two, saw a little bit of bump in the COVID numbers in the hospital itself. We were plummeting, and then all of a sudden we had a little bit of a repeat spike. So I think it's not time to take the masks off or anything like that. It's going to be one of those things that's still going to be perpetually present for probably the next year or so. I know we all want to get vaccinated, take off the mask, go back to life as normal. But it's going to be a little bit of a slow process.
Yeah, I think you're absolutely correct. I was listening to a cardiologist give a lecture, and somebody had asked a question in terms of when do you think it's all going to end? And he said, I'm not expert, but he kind of had he was dipping his toes in running the command center out in California with the Kaiser Permanente, I think it is, health system. But he said, as far as things go here in California, I see it extending to the end of 2021. People taking precautions and life being different and not being returned to normal. I see that extending to the end of 2021. And this was months ago that I listened to his lecture, and I think that still holds true today. I think
I think that's reasonable. I mean, if you look back at the Spanish flu pandemic in the 19-teens, it was kind of a 2-year thing, and that's probably what we're looking at. We'll see. So
yeah,
I'm in a couple minutes. By the way, I gotta go pick up my kids.
Yeah, no problem. Before I let you go, one last thing. Any advice? Any aspiring physicians, emergency medicine, or EMS fellowship? Anything any wisdom you want to instill upon them?
Yeah, I mean, I would say it's definitely a long path, but I really loved medical school. I actually think I liked medical school more than I did college. I just really liked learning the material. I went into medical school saying I want to do emergency medicine and I want to do an EMS fellowship, and I was told a million times that everybody changes their mind. And I liked all the rotations I did as a medical student. When you do surgery, internal medicine, pediatric, I liked it all. But when I, started doing rotations in the emergency department, it felt like coming home. And then when I, started getting involved in pre-hospital medicine from the medical direction side during residency, it was the best thing ever. It's a long path, but it's a fun, enjoyable path. There's certainly a lot of stressors in there, a lot of life stressors on top of the academics and the training and learning how to be a resuscitationist. But I think kind of getting towards the end of my training, my final training now, I guess, as a fellow, I think it's all worth it, and kind of enjoy the ride if you're going through it. It's not something that at times is enjoyable, I would say, when you're studying for things like the MCAT to get into med school, or your board exams when you're in medical school and a resident, and then there's always another exam. Kind of is what it seems, but the road is long. But if it's what you want to do, it's what you're passionate about. If your family is behind you, which I was very fortunate that my wife is, and it's a road well traveled, and it's definitely worth it in the end.
Beautifully said. Thank you so much. I appreciate it. This was actually an amazing talk. This is probably my favorite interview yet. So thank you for the time.
Awesome.
Thank you for coming on.
It's a good time to pick up those kids. My kids are now, I know I talked about being pregnant. Now they're almost 15 months. And
oh my goodness.
So I have two girl twins. So
father first, doctor second. So go take care of your responsibilities. I really appreciate you being on here. It was great talking to you.